করা যাবে, বুঝতে পারছো?
হ্যাঁ স্যার, বুঝতে পেরেছি স্যার।
আচ্ছা ঠিক আছে, যে অংশটা বাকি ছিল যে ক্রেনিয়াল নার্ভস, ডেভেলপমেন্ট অফ ক্রেনিয়াল নার্ভস, cranial nerves, sensory ganglia of cranial nerves originate from the ectodermal placodes. So by the fourth week of development, nuclei for all the 12 cranial nerves are present. Here nuclei of cranial nerves are mentioning here. So all except the olfactory, that is the first cranial nerve, and the second cranial nerve, that is the optic nerves, arise from the brain stem. Arise from the brainstem, nerve 1, cranial nerve 1, and all cranial nerves except 1 and 2 derive from the brainstem. And of these, only the oculomotor, that is the third cranial nerve, arrives outside the region of the hindbrain. This is the hindbrain, and third cranial nerves arrives outside the hindbrain. These segments from which the cranial nerves arise are known as rhombomeres. So in the hindbrain, this is the hindbrain, rhombencephalon. And the hindbrain proliferation centers in the neuroepithelium establish 8 distinct segments. These distinct segments are known as rhombomeres. These are rhombomeres. Here are the rhombomeres. So there are 8 rhombomeres. These rhombomeres give rise to motor nuclei of the cranial nerves 4, 5, 6, 7, 9, 10, 11, and 12. Here are some cranial nerves we are showing. Here some cranial nerves we are showing here. It is the nucleus of 9, 10, this is 11, 7, and 8. These the cranial brainstem. Motor neurons of cranial nerves lie within the brainstem, but the sensory ganglia are outside the brain. Thus, the organization of the cranial nerves is homologous to that of the spinal nerves, although not all cranial nerves contain both motor and sensory fibers. But most of the cranial nerves contain motor and sensory fibers. The motor neurons, the cranial nuclei, lie within the brain, but sensory ganglia outside the brain. We will show you later in the figures. So cranial nerve sensory ganglia originate from the ectodermal placodes and the neural crystals. Ectodermal placodes include the nasal placode, otic placode, optic placode, and other epibronchial placodes represented by ectodermal thickening to the pharyngeal arches. And from which pharyngeal arches, which nerves arise, you can see from few textbooks. The parasympathetic, that is visceral efferent nerve fibers or ganglia, are derived from the neural crystals, and their fibers are carried by cranial nerves 3, 7, 9, and 10. So these parasympathetic ganglion also arrive from the neural crystals, and their fibers are carried by cranial nerves 3, 7, 9, and 10. This is 7, this is 9, and this is 10. 3 cannot be seen here. And now the basal plate. Here is the basal plate. This is the alar plate. This is basal. The basal plate contains motor nuclei which divide into 3 groups. Here remains the motor nuclei which can be divided into 3 groups, such as general somatic efferent. These are the somatic efferent groups: general somatic efferent, special visceral efferent, general visceral efferent. This is the general visceral efferent. This is special visceral efferent, and this is general. Somatic efferent. The basal plate contains motor nuclei which divide into 3 groups. This is the general somatic efferent group. This is the general somatic efferent group. Special visceral efferent group which lie intermediate. This is the special visceral efferent groups for 9, 10, and 11. And general visceral efferent group lateral in position. This is general visceral efferent which lie lateral. So the LR plate, these are the LR plate. LR plate contains 4 groups of sensory relay nuclei. LR plate contains 4 groups of sensory relay nuclei, special somatic efferent group. These sensory nuclei we know as efferent, and motor nuclei we know as efferent. So LR plate contains 4 groups of sensory relay nuclei, which is special somatic efferent groups. Special somatic efferent. Special somatic efferent group lateral in position. Special somatic efferent. This is the special somatic efferent which lies laterally and receives impulses from the ear by way of vestibulocochlear nerve. This somatic efferent receives impulse from the vestibulocochlear nerve from the ear. And general somatic efferent receives impulses from the head and face. General somatic efferent. General somatic efferent receives impulse from the head and face, and special visceral efferent group. Special visceral efferent. There is a special visceral efferent. Special visceral efferent group receives impulses from taste buds of the tongue and from the palate, oropharynx, and epiglottis. And general visceral efferent. The general visceral efferent. This is general visceral efferent. General visceral efferent groups medial in position, which is medial in position, receives interoceptive information from the GIT and heart. So here are 4 groups of nuclei. These are the special somatic efferent groups. Special somatic efferent. Then general somatic efferent. General somatic efferent. The special visceral efferent and general visceral efferent. The special somatic receives impulses from the taste buds of tongue and palate, oropharynx, and epiglottis. And general visceral efferent. General visceral efferent receives interoceptive information. So origins of the cranial nerves and their composition in tabulated form. You can see this table in your books. We have cranial nerves, olfactory, optic, and oculomotor. Brain region olfactory develops mesencephalon. Optic nerves is the second cranial nerve developed from diencephalon. Oculomotor, third cranial nerve developed from mesencephalon. And they are so special visceral efferent. Olfactory is the special visceral efferent, innervation to nasal epithelium for smell. And optic occlude diencephalon, special somatic efferent, vision from retina for vision. And oculomotor or third develops in the mesencephalon. General somatic efferent, superior medial rectus, inferior oblique, levator palpebris superioris. And general, they also receive innervation through general visceral efferent from ciliary ganglia, and innervation from sphincter pupillae and ciliary muscles. The trochlear, trigeminal, I am not going through details. You can see from these books. The abducens nerve from the mesencephalon, facial from the mesencephalon, vestibulocochlear also from the mesencephalon, glossopharyngeal myelencephalon. And the general somatic efferent, special visceral efferent, and vestibulocochlear, special somatic efferent. You can see these tables from your books. I'm not doing details. And vagus nerve, that is the 10th cranial nerve, develops in the minus colon, special visceral efferent, inferior ganglia, and general visceral efferent, superior ganglia. Innervation from palate and epiglottis for taste and base of the tongue, pharynx, larynx, trachea, heart, esophagus, stomach, intestines through general visceral efferent. You see this table in your books in details. Final accessory, hypoglossal. So autonomic nervous system. What is autonomic nervous system? Autonomic nervous system is that part of the nervous system which we cannot control by ourselves. Autonomic means স্বায়ত্তশাসিত। autonomic মানে নিজে নিজে যে কাজ করে, আমাদের নিজেদের ইচ্ছা বাইরে যে কাজগুলো আমাদের গঠিত হয় সেই নার্ভাস সিস্টেমটা আমরা বলি অটোনমিক নার্ভাস সিস্টেম। তাহলে অটোনমিক নার্ভাস সিস্টেম regulates a variety of body process which is not within our control. So this autonomic nervous system is the part of the peripheral nervous system that is responsible for regulating involuntary body functions such as heartbeat, blood flow, breathing, digestion, sexual activities. An autonomic nervous system is also made up of a third component known as enteric nervous system. The other two components are sympathetic and parasympathetic. We are showing here functionally the autonomic nervous system can be divided into two parts. Sympathetic portion of in the thoracolumbar region and parasympathetic portion. Another portion is enteric nervous system which supplies our gut. So sympathetic nervous system, in the 5th week of embryonic life, the cells originating in the neural crest of the thoracic region migrate on each side of the spinal cord toward the region immediately behind the dorsal aorta. It is dorsal aorta, the aortic ganglia. They form a bilateral chain of segmentally arranged sympathetic ganglia interconnected by longitudinal nerve fibers. The sympathetic ganglia, they form a chain, sympathetic trunk. This chain is known as sympathetic trunk. They form a bilateral chain of segmentally arranged sympathetic ganglia interconnected by longitudinal nerve fibers. Together, they form the sympathetic chains on each side of the vertebral column. So, during development in the embryonic life, the sympathetic chains developed on each side of our vertebral column. From their position in the thorax, neuroblasts migrate toward the cervical and lumbosacral region, extending the sympathetic chains to their full length. Although initially the ganglia are arranged segmentally, this arrangement is later obscured, particularly in the cervical region by fusion of the ganglia. So in the cervical region, several sympathetic ganglia are fused in the cervical region. Some sympathetic neuroblasts migrate in front of the. This is the pre-aortic ganglia, such as the celiac and mesenteric ganglia. Other sympathetic cells migrate to the heart, lungs, and gastrointestinal tract, where they give rise to sympathetic organ plexuses. Here, sympathetic nerves supply in the organs different viscera, forming organ plexuses. So, the important function of our sympathetic nervous system is to maintain our digestion, blood pressure, heart rate, micturition and defecation, pupillary response, breathing or respiratory rate, sexual response, body temperature, metabolism, electrolyte balance, production of body fluids including sweat and saliva, and emotional response. These all are maintained through this sympathetic nervous system or autonomic nervous system. So the contributions of the neural crest cells and placodes to ganglia of the cranial nerve. Once the sympathetic chains have been established, this is the visceral efferent columns of the sympathetic chain. Once the sympathetic chains are established, nerve fibers originating in the visceral efferent column. This is the visceral efferent column or intermediate horn spinal cord. Nerve fibers originating in the visceroinferent column or the intermediate horn of the thoracolumbar segment, that is thoracic 1 to lumbar 1 or lumbar 2 of the spinal cord, penetrate the ganglia of the chain. The sum of these nerve fibers synapse at the same levels in the sympathetic chains to pass through the chains to pre-aortic or collateral ganglia. Here the sympathetic ganglion, and from this sympathetic ganglia, some fibers pass to these collateral ganglia or pre-aortic ganglia. The sum of these nerve fibers synapse at the same levels, at the level of the sympathetic ganglion. At the same levels, they pass through the chains to pre-aortic or collateral ganglia. The pre-aortic or collateral ganglia. They are known as preganglionic nerve fibers. This nerve fiber is known as preganglionic nerve fiber. This is the preganglionic nerve fibers. So, passing from the spinal nerves to the sympathetic ganglia, they form the white communicating rami. Here, the white communicating rami. This is the white communicating rami. Since the visceroefferent column extends only from the first thoracic to second or third lumbar segment of the spinal cord, white rami are found only at these levels. So, these white rami or white ramus is found only in the thoracolumbar region, that is from thoracic 1 to lumbar 1 or lumbar 2 spinal nerves region. These white ramus are found. The axons of the sympathetic ganglion cell, the postganglionic fibers, these are the postganglionic fibers. This is the axon of the sympathetic ganglion cells. This is the sympathetic ganglion with the preganglionic nerve fibers. This is the postganglionic nerve fibers. Postganglionic fibers have no myelin sheet. These postganglionic nerve fibers have no myelin sheet. They either pass to other levels of the sympathetic chain or extend to the heart, lungs, and intestinal tract. These postganglionic fibers came into the intestinal tract or here in the blood vessels. The other fibers, the gray communicating rami, this is the gray communicating rami. This is the gray communicating rami, pass from the sympathetic chain to the spinal nerves and from there to the peripheral blood vessels. This is the peripheral blood vessels. This is the gray communicating rami. These postganglionic fibers pass to the blood vessels, hair and sweat glands. This is the hair and these are sweat glands of the skin. The gray communicating rami are found in all levels of the spinal cord. So, white communicating rami are found in the thoracolumbar region and gray communicating rami are found in all levels of the spinal cord. Now, suprarenal gland. The suprarenal gland, as part of the autonomic nervous system, also developed from two components, that is mesodermal portion and ectodermal portion. Mesodermal portion which form this cortex. This is the cortex of the suprarenal gland. This is the medulla of the suprarenal gland. So, ectodermal portion which forms the medulla. This is the cortex which is mesodermal in origin, and this is the medulla which is ectodermal in origin. During the 5th week of development, mesothelial cells between the root of the mesentery and the developing gonad begin to proliferate and penetrate the underlying mesenchyme. Here they differentiate into the large acidophilic organs. This is the acidophilic organs which form the fetal cortex. This is the fetal cortex of the endocrine suprarenal gland or primitive cortex of the suprarenal gland. So shortly afterward, a second wave of cells from the mesothelium penetrates the mesenchyme and surround the original acidophilic cells. These cells penetrate into the mesenchyme surrounding these primitive cortex. These are known as chromatin cells. Chromatin cells. These cells, smaller than those of the first wave, later form the definitive cortex of the gland. And after birth, the fetal cortex regresses rapidly, except for its outermost layer, which differentiates in the reticular zone. This is the reticular zone, zona reticularis. The adult structure of the cortex is not stiff. This cortex is not developed fully until a person develops attains puberty. So during puberty, the cortex of the cerebral gland develops completely. So while the fetal cortex is being formed, this is the fetal cortex. While this fetal cortex is being formed, the cells originating in the sympathetic system, the neural thread cells invade its medial aspect. This is the cells arising from the neural thread cells invade the medial aspect, where they are arranged in cords and clusters. These cells give rise to the medulla of the substernal gland. Here, the medulla of the substernal gland.
বুঝিল কিছু বুঝাই দেন
This is the medulla of the
স্যার
substernal
কথা
gland.
কিছু বুঝলাম
They stain yellow brown with chrome source, and hence they are known as chrome means yellow. In embryonic life, chromosomes cells are scattered widely throughout the embryo, but in the adult, they only persist group in the medulla of the adrenal gland. So we should keep in mind that during embryonic life, chromosome cells are scattered widely throughout, but in the adult, they only persist in the medulla of the adrenal gland. So neurons in the brainstem and the sacral region of the spinal cord give rise to preganglionic fibers, which we mentioned earlier. Fibers from nuclei in the brainstem travel via the oculomotor, facial, glossopharyngeal, and vagus nerves. Postganglionic fibers arise from the neurons, derive from the neural cells, and pass to the structures, the innervates such as pupil of the eye, salivary glands, and other tissues. Then some clinical congenital anomalies may develop during this development. The most common is congenital megacolon, which we know as Eardrum disease. You should keep in mind or memorize the spelling of the Eardrum disease. You may be asking your fiber policy, what is Eardrum disease? Eardrum disease is a congenital anomaly that develops during embryonic period, also known as congenital megacolon. So congenital megacolon Eardrum results from a failure of the parasympathetic ganglia to form in the wall of part or all of the colon and rectum because the neural crest cells fail to migrate. যদি কোনো কারণে neural crest cells গুলো migrate করতে না পারে, সেই ক্ষেত্রে parasympathetic ganglia আমাদের intestine কোলনে, বিশেষ করে কোলন এবং রেকটামে প্যারাসিম্পাথেটিক গ্যাংলিয়া যদি না ডেভেলপ না করে, সেক্ষেত্রে কনজেনিটাল মেগাকোলন বা Eardrum disease ডেভেলপ করতে পারে। The congenital megacolon results from a failure of parasympathetic ganglia to form in the wall of part or all of the colon and rectum because the neural cells fail to migrate. So the rectum, basically, it is mostly genetic disorder, and the rectum is involved in nearly all cases. And the rectum and sigmoid colons are involved in 80% of the affected cases of congenital megacolon. The transverse and ascending portion of the colon are involved in only 10 to 20% cases. The colon is dilated above the affected region, which has a small diameter because of tonic contraction of the non-innervated musculature. Here we are seeing this is the normal colon. Here the parasympathetic ganglions are placed in their definitive places. These are the ganglion containing enteric neurons and glia. But this is the congenital megacolon. Eardrum is the sigmoid colon. This is rectum. Here, no enteric neurons. In this case, no enteric neurons. This is the transition zone to low enteric neurons. So, what happens in case of Eardrum disease or congenital megacolon? There is bilious vomiting, delayed cases of meconium, and severe constipation. The fetus may even die. And if the baby persists, he may develop malnutrition, bowel inflammation and perforation risk, abdominal distension, the পেট অনেক বড় হয়ে যায়, abdominal distension and enterocolitis. যেহেতু তার বাউল মুভ করে না, বাউল পাস করে না, সেই জন্য bilious vomiting হয় এবং সেখানে ব্যাকটেরিয়াল ওভারগ্রোথ হয়ে enterocolitis develop. So here is the picture of the congenital megacolon or Eardrum disease after operation. This is a patient of Eardrum disease. This is intestine Eardrum disease. So, congenital megacolon is a life-threatening congenital developmental anomaly. if parasympathetic ganglia are not developed. আচ্ছা, তো আমরা এখন একটা লেকচারে যাই, এন্ট্রি এবং আই এবং ইউ। জসিম ভাই, ওই যে আইটা দিয়ে দেন, আই দিয়ে দেন, আইটা। So now development of eye and ear. So here we can see the optic cup and lens vesicle. So developing eyes appear in the 22-day of embryonic life as an optic groups. Here we are showing this is the optic groups on either side of the prosencephalon or forebrain. On sides of the forebrain. With closure of the neural tube, these groups form optic vesicles. This is optic vesicle. So at first, optic groups are formed on each side of the forebrain, and later it develops into optic vesicle. Optic vesicle here. This is the optic vesicle. The optic vesicle invaginates and forms the optic cup. Here is the optic cup. This invagination inferiorly forms choroid fissure. Here, choroid fissure is formed, which allows hyaloid artery to reach inner chamber of the eye. This hyaloid artery later develops the central artery of the retina. During 7th week, lips of choroid fissure fuse and forms future pupil. The lips of choroid fissure fuse to form. Here eye development starts at the 22nd day before neural tube closure. This is the optic placote. This is diencephalon. On each side of the diencephalon, the optic groups are formed. Then optic placote, optic groups, optic vesicles. And this is optic stalk. Optic stalk later develops into optic nerve. And this is the cavity of the forebrain or the prosencephalon. Here optic sulcus or optic group is formed. Optic group is deepening. Optic group is deepening, and then optic vesicle is formed. Formation of the optic vesicle and optic stalk. This is optic stalk. Optic stalk. Optic vesicle or stalk neuroectodermal in origin. Lumen of the optic vesicle, this is the lumen. Lumen of the optic vesicle is connected with the third ventricle. So the lumen of the optic stalk. This is the lumen of the optic stalk. As the optic vesicle comes in contact with the surface ectoderm, it induces it to thicken and forms lens placote. Here lens placote is formed. When the optic vesicle comes in contact with the surface ectoderm, then lens placote becomes to start or form. It induces it to thicken and forms lens placote, which is the primordium of lens. So lens is ectodermal in origin. Usually surface ectoderm. So lens is ectodermal in origin. And as the lens vesicle is being formed, optic vesicle invaginates to form double layered optic cup. This is the double layered optic cup. Double layered optic cup. This is lens vesicle, surface ectoderm. So optic vesicle, optic cup, optic stalk, lens placote, choroidal fissure. Choroidal fissure, muscular mesoderm invade in the fissure. This mesoderm later forms hyaloid vessels and vitreous humor. Only the proximal part of these vessels persist as a central artery or central vein of the retina. So this development of retina, 2 layers of optic curve, and the 2 layers of the optic curve. Development of optic nerve develops from the optic stalk through the axons of ganglion cells. Retinal development is a congenital anomaly where the pigmented layer of the retina is separated from the retina. So optic vesicles, when come in contact with the ectoderm, it induces formation of the lens. We mentioned earlier, lens placode which invaginates into and develops into lens vesicle. This is the lens vesicle. During the 5th week, lens vesicle loses contact with surface ectoderm and lies in mouth of the optic curve. Here lens lies in mouth of the optic curve. This is the surface ectoderm. This is the lens pitch. This is the lens vesicle. And this is the surface ectoderm. This is the lens vesicle, outer layer, inner layer of the optic nerve. The outer layer is the inner layer of the optic. So outer layer of optic curve forms pigmented layer of the retina. This is the pigmented layer of the retina, which is developed from the outer layer of the optic curve. The posterior 4/5, this portion. The posterior 4/5, which we know as pars optica retinae, contains cells that differentiate into light receptive elements, rods, and cones. So these posterior 4/5, that is the pars optica retinae. From this region, the rods and cones. These cells, rods and cone cells, are light sensitive part of our retina. So ultimately, from the optic stalk, optic nerve is derived in optic curve. From optic curve, retina, dilator pupillary muscle, interpupillary, epithelium of the iris, epithelium of the ciliary body develops. It is the central hyaloid artery, which ultimately develops into central artery of the retina. So adjacent to photoreceptive layer is the mantle layer, which gives rise to outer nuclear layer. The outer nuclear layer, this is the outer nuclear layer, that is the nuclei of rods and cones. These are the nuclei of the rods and cones. Inner nuclear layer, nuclear of the bipolar cells. This is inner nuclear layer, nuclei of the bipolar cells, and ganglion cell layer. The ganglion cell layer. Nerve fibers in these zone forms optic nerve. These nerve fibers collectively form optic nerve. The anterior fifth of the inner layer. This is the anterior fifth of the inner layer. Anterior fifth of the inner layer. We know as pars ceca retinae, divides into pars ididica retinae and pars ciliary retinae. So pars ididica retinae forms inner layer of the iris, and pars ciliary retinae participates in the formation of the ciliary body. Ciliary muscles will be part of the ciliary body. The sphincter and dilator pupillary develop from the underlying ectoderm of the optic curve. The pars ciliary retina is covered by a layer of mesenchyme that forms ciliary muscles. Here are the ciliary muscles. Development of iris, epithelium, both layers of the retina, stroma, mesenchyme, and muscles, outer layer of the retina. And development of ciliary body, epithelium, both layers of the retina, stroma from mesenchyme, muscles also from stroma and muscles of the retina, and epithelium from layers of the retina. But in case of iris, epithelium develops from retina, epithelium and stroma from mesenchyme, muscles, outer layer of the. So now, what is ora serrata? This is ora serrata. Here is the ora serrata. This is the ora serrata. Ora serrata is the junction of photosensitive and non-photosensitive retina. Ora serrata is the junction. This is the junction of photosensitive and non-photosensitive region of the retina. Lies between the limbus. This is the limbus. Limbus means sclerocorneal junction. The sclera and the corneal junction. This is limbus and the equator of the eye. So here is the ora serrata. Masseter lies between the limbus and the retina of the eye. Here is retinal detachment. Retinal detachment between the nuclear layer is detached. Retinal detachment, retinal tear. This is a medical emergency between two layers of retina. This is the coloboma. Failure to close choroidal fissure. Here, choroidal fissure is open. So this is coloboma iris. Keyhole appearance in the iris. Keyhole appearance. চাবির তালার চাবির মতো তালাতে যে চাবি ঢোকানোর যে ছিদ্রটা থাকে সেটার মতো দেখতে keyhole appearance in iris. Follow AD. So from mesoderm posteriorly divides into two layers. Anteriorly vacuolization occurs and development of sclera, choroid, cornea, conjunctiva, iris. Surface ectoderm, double folding occurs in the surface ectoderm. Double folding here, the double folding of the surface ectoderm, which gives rise to the conjunctiva and iris. The conjunctiva and in front iris. This is iridopeupillary membrane. This is known as iridopeupillary membrane. If this iridopeupillary membrane persists, iridopeupillary membrane. So at the end of the fifth week, eye primordium is surrounded by loose mesenchyme, which differentiates into inner vascularized pigment layer. This is the inner vascularized pigment layer. This is known as choroid. The inner vascularized pigment, which we call as choroid. Outer layer, that is sclera. This is the outer layer. Which we call sclera, that is continuous with the durameter around the optic nerve. The cornea is formed by an epithelial layer derived from the cornea. This is the cornea. This cornea. This is the sclerocorneal junction. And this vascular layer is known as choroid. So cornea is formed by from surface ectoderm, outer epithelium of the cornea, conjunctiva, lining of the iris, dorsal glands, eyelashes, these are derived from the surface ectoderm. Here we are seeing persistent iridopupillary membrane. This is iridopupillary membrane. If it persists, the iris line. Persistent iridopupillary membrane. This is congenital cataract. In case of newborn baby, congenital cataract. It occurs due to torch infection, toxoplasmosis, rubella, cytomegalovirus. In some cases, herpes virus infection may cause congenital cataract. So, vitreous body. Mesenchyme not only surround the eye primordium from outside, but also invades inside the optic cup through choroid fissure and forms vitreous body. Here is vitreous body. Here is the vitreous body. Choroid, if the mesenchyme penetrates, and mesenchyme penetrates the optic cup through the choroid fissure, it forms vitreous body. So optic cup is connected to brain by optic stalk. Here is the optic stalk. This is optic stalk. Optic cup is connected to brain by optic stalk, which has choroid fissure on its ventral surface. Here the choroid. Optic stalk is transformed into optic nerve. This optic stalk later develops into optic nerve. Each center contains a portion of the hyaloid artery. This is the hyaloid artery, later called central artery of retina. So optic nerve develops from the optic stalk, and in its center, hyaloid artery develops into central artery of the retina. The second cranial nerve, optic nerve is the second cranial nerve. Optic nerve encloses retinal vessels. These are the retinal vessels, formed by axons of the ganglionic cells and covered by meningeal layers, myelinated by oligodendrocytes. So optic nerve myelination gets myelination from the oligodendrocyte. There is some congenital anomalies of the eyes. This is an iridia. You can see here the red eye, an iridia. There is no iris in this eye. No iris. This is an iridia. An iridia means the complete or partial absence of colored part of the eye. This is যেটাকে কালো চোখের যে কালো অংশটা সেটাই তো আইরিস, এখানে ওর কালো অংশটা নাই। The black portion of the eye is absent here. It is no irish. It is an IRID. It is congenital, hereditary, bilateral, and extreme form of irish hypoplasia. Irish does not develop here. They don't have foveal reflex. Visual acuity is low, and cataract and glaucoma may be present with an IRID. The baby may have cataract and glaucoma with an IRID. This is the cyanophthalmia or cyclopia. Cyanophthalmia or cyclopia, this is loss of midline structures. Cyanophthalmia, here sorry, some elements of two eyes are fused and form a single eye in the middle region of the forehead. A single eye in the middle region of the forehead. This is cyanophthalmia or cyclopia. And anophthalmos. This is anophthalmos. It is congenital. Anophthalmos means absence of eye. Their orbit is present, but no eye is there. Due to complete failure of outgrowth of primary optic vesicle. If primary optic vesicle is not developed completely, then anophthalmos develop. That is no eye. Absence of globe and ocular tissues are absent. So these are the congenital anomalies in the eye. There are some factors which may contribute to this development of cyanophthalmia, which include alcohol, maternal diabetes mellitus, mutation of some genes such as sonic hedgehog genes, and abnormal cholesterol metabolism. This may lead into congenital anomalies of the eyes. These are the cyanophthalmia. The two eyes are fused in the middle. So the eyes begin to develop as a pair of outpocketings on each side of the forebrain at 22 days of development. The optic vesicles conduct the surface ectoderm and induce lens formation through the formation of the lens placode and then through a groove, that is the choroid fissure. The hyaloid artery later becomes the central artery of retina, enters the eye, and PAX6, the gene, the master gene for eye development, cornea develops from both ectoderm. Now the ear. So develops from three distinct different parts: the external ear, middle ear, and the internal. Here we are showing this is the internal ear, this is the middle ear. This is the external acoustic meatus. These are the bones of the ear, the stapes, incus and malleus. These are semicircular canal, endolymphatic sac, cochlear aqueduct, duct of cochlea, and pharyngotympanic tube. External auditory images, middle ear and internal. So internal ear, first indication of the ear can be seen in embryos. First indication of ear can be seen in embryos at approximately 22nd days as a thickening ectoderm on each side. The thickening ectoderm on each side of the rhomboencephalon, that is the hindbrain, through the otic placodes, which resonate rapidly and form the otic or auditory vesicles, also known as otocyst. So ear development also starts in the 22nd day of embryonic life. Which these otic placodes or auditory vesicles divides into a ventral component that gives rise to the saccule and cochlear duct and dorsal component. This is the otic vesicle, the otic pit. Invaginating placode. Otic placode invaginates to form otic placode and then otic. The otic vesicle develops into ventral component that gives rise to sacral and cochlear duct, and dorsal component forms atrial, semicircular canals, and endolymphatic duct. Together, these epithelial structures form the membranous lipid. They are the otic vesicles. Otic vesicles. So middle ear, tympanic cavity and auditory tube. The tympanic cavity originates in the endoderm. Tympanic cavity is endodermal in origin, derived from the first pharyngeal pouch. The distal part of the pouch, which is the distal part of the pharyngeal pouch, the tubotympanic recess widens and gives rise to the primitive tympanic cavity, and the proximal part remains narrow and forms the auditory tube or eustachian tube. Here the auditory tube. This is the auditory tube or primitive tympanic cavity. This is primitive tympanic cavity. Wall of the inner ear. Eustachian tube. In the ossicles, the malleus and incus are derived from the cartilage of the first pharyngeal arch. Malleus and incus develop from the cartilage of the first pharyngeal arch, and stapes is derived from that of the second. Stapes is derived from the second pharyngeal arch. So regarding external ear, the external auditory meters develops from the dorsal portion of the first pharyngeal plate. Just to the first pharyngeal plate, the external auditory meters develop for it. At the beginning of the third month, epithelial cells at the bottom of the meatus proliferate, forming a solid epithelial plate, which is meatal plug. And in 7 months, this plug dissolves, and the epithelial lining of the floor of the meatus participates in formation of eardrum. And occasionally, the meatal plug persists until birth, resulting in congenital deafness. The external auditory meter develops from the first pharyngeal cleft. Eardrum or tympanic membrane. Eardrum is made up of ectodermal epithelium lining at the bottom of the auditory meatus, endodermal epithelial lining of the tympanic cavity, and intermediate layer of connective tissue, mesoderm. So ectoderm, endoderm, and mesoderm. These three layers, the tympanic or eardrum develops. The first membrane, tympanic membrane, first pouch auditory tube, the tympanic membrane, first branchial membrane. So in the middle ear and auditory tube extends from nasopharynx to middle ear, derived from first branchial pouch, which is endodermal in origin. This is external auditory meatus. External auditory meatus derived from first branchial cleft, which is ectodermal in origin. So the auricles develops from 6 mesenchymal proliferations at the dorsal ends of the first and second pharyngeal arches surrounding the first pharyngeal cleft. This swelling, that is auricular hillocks, 3 on each side of the external meatus, later fuse to form definitive auricle. Auricle means spina, the external ear, part of the external spina. Initially, the external ears are in the lower neck region, but with development of the mandible, they ascend to the side of the head at the level of the eyes. প্রথমে এরা এক্সটার্নাল আই ইয়ারগুলো থাকে হচ্ছে ঘাড়ের নিচের দিকে, লোয়ার নেক রিজন, কিন্তু during the development of mandible they ascend to the side of the head at the level of the eyes. So there are some congenital abnormalities in deafness, external ear abnormalities. The congenital deafness, usually associated with deaf mutism, may be caused by abnormal development of the membranous and bony labyrinths, or by malformations of the auditory ossicles and eardrum. If the auditory ossicle, that is malleus, incus, and stapes, that do not develop, and also eardrum also does not develop, then the child may have congenital deafness. In the most extreme cases, the tympanic cavity and external meatus may be absent. External ear. External ear defects are common. They include minor and severe abnormalities. The external ear abnormalities, they may be minor or may be severe. The preauricular appendages and pits. The preauricular appendages, then the preauricular pits, Preauricular aneurysm pits are skin tags and shallow depression. This is the shallow depression, respectively anterior to the ear, in front of the ear. This is another congenital malformation which you see earlier, Tresor Collinson. Here, congenital deafness, malformation of the face, and maldevelopment in the mandible. This is Tresor Collinson syndrome. If the neural cells fails to progress in the first pharyngeal arch, then baby may have Tresor Collinson syndrome. In Tresor Collinson syndrome, there is congenital deafness as the eardrum or the ear ossicles do not develop properly, and their facial malformations the forehead on the whole, eyelid deviated on the side, malar bridge not developed, and hypoplasia of the mandible. These all contribute to the development of Tresor Collinson syndrome. So with this, we conclude today's session on development of eyes and ears. If you have any questions, let me know through our email address. So we wish to see you on time if everything is okay. So thank you. সবাই ভালো থেকো। সেটা আমি এখানে শেষ করি।
Assalamu alaikum.